Hi, Fabio.
Hey, it's Westover. How are you?
Cheers.
So we have a 50-ish-year-old lady in the EMU, and I think I saw a left temporal seizure, but the imaging was normal, so I'm a little bit puzzled.
We should invite Dr. Klein to come over here if we have a question about the imaging.
We should. Oh, he's already here.
What?
Dr. Klein.
Awesome.
What do you know?
Well,
Great to see you guys. What a
Nice
coincidence.
seeing you here.
Yeah.
I think
Yep.
Fabio's right. There is a lot going on here. So that we have a left-sided seizure that looks like it's coming, probably in the, left temporal chain. You can see it really nicely down there on the bottom set of electrodes, sort of around T3, T1 derivation. So I think though, if this patient if it's left-sided seizures on EEG, but nothing on the MRI, that is a little concerning.
I looked at the scan for hours. I didn't see anything abnormal.
Yeah, I'd like it if there was a sort of nice correlation between the imaging and the EEG before we propose taking out the left temporal lobe. But I think maybe Dr. Klein is pretty good at seeing subtle findings. So I say we give it a look together with him.
Let's do it.
Huh?
I already labeled it. Yeah. While you were looking at the EEG, got it all done. So, 57-year-old woman with left temporal seizures. So the big question is, what do we look for on the MRI? What do we try to find here? So I put up the two key sequences, which is a T1 and T2 flare in this case, where they've suppressed out the bright signal from fluid. And what we can see here is an abnormality that's focal and involving the medial part of the left temporal lobe. And I'll point to it here, but I've even put some arrows here that shows us that there are the characteristic features of left hippocampal sclerosis. And so what we're talking about there on the T1 image is a sort of structural shrinking, a smallness of the left hippocampus compared to the more normal looking one on the right side here. And then on the T2 image, perhaps a little bit easier to see or more dramatic, is the abnormal hyperintensity. So the bright signal in the left hippocampus here that we don't see as much of on the right side. So this is what we would call unilateral, or in this case, a left hippocampal sclerosis.
It stands out really nicely here on this flare.
So let's move on. So, when we consider pathologies that are associated with epilepsy, kind of the main archetypes, and of course we're focused on number one here, would be malformations of the brain and acquired structural lesions. So that would include dysplasias, so malformations of cortical development, of cells getting to where they're supposed to be during development. And then more acquired things like sclerosis and gliosis, either from prior injuries or things that occur during our lives. The other major categories of disease that can be associated with epilepsy, obviously inflammatory conditions, of which hippocampal sclerosis that we're talking about today isn't an example of. But of course, we know about limbic encephalitides, which can be both infectious, like in herpes simplex virus encephalitis, or non-infectious, like in paraneoplastic or autoimmune forms of limbic encephalitis. So all of those are inflammatory conditions that can particularly involve the hippocampus and produce seizures. Third category would be altered gene expression. So this is some of the congenital or inherited epilepsy syndromes that can often be or sometimes be associated with malformations of the brain as well. But sometimes you'll see on imaging a structurally normal brain, but an elevated tendency to have seizures in syndromes like this. And then finally, we should remember that in neurodegenerative conditions, and Alzheimer's disease being just one of the common ones, that the risk of having seizures is increased. And it's not only in diseases like Alzheimer's, but in diseases like multiple sclerosis and things like that over time produce lesions that accumulate in the brain. That sort of neurodegeneration can also increase the risk of having seizures. So just to touch briefly on hippocampal development, I'm not going to go into a lot of detail here, but just to show you that it starts out during development as kind of a worm-like structure that as we get through development, starts to accumulate these different folds, much like other areas of the cortex. And then this much more complex structure develops over time during fetal development to a point where the head of the hippocampus has these characteristic digitations, which we'll be able to see nicely on imaging. And then the body of the hippocampus remains kind of worm-like, but as you can see, there is this sort of ultrastructural parts of them. And then obviously the white matter that's coming out of the hippocampus, which is called the fornix, we'll talk about where that projects, and how it can be relevant on imaging studies in patients with hippocampal sclerosis. So I think one of the most important themes or ideas about imaging the hippocampus to get the most high quality views, it really boils down to two factors. Number one is having as high a Tesla magnet as the patient can withstand. So the higher Tesla images you acquire, the more detail you see. You can make the field of view smaller so you can really focus in on the structure of the hippocampus. And in particular, if you use this coronal oblique angle as opposed to a pure coronal angle in acquiring the images, this sets you up to acquire images directly perpendicular to the long axis of the hippocampus. And in that way, you're not cutting across the hippocampus in an oblique way. And so you can make a better evaluation of hippocampal volume and areas of sclerosis even on MRI images.
Is that what the epilepsy protocol kind of is all about, Dr. Klein?
Yeah, the epilepsy protocol typically involves thin cuts through the medial temporal lobe, including the hippocampus, and very often you'll try to make the angulation so that you're really perpendicular to that long axis of the hippocampus. It's an important point. So if we do ex vivo imaging, as in this image, you can see here beautiful sort of cellular lamination within the hippocampus that really shows you images that are almost as nice as what you'd see histologically. And in cases like this, if this is a normal hippocampus, but if it was an example of someone who had hippocampal sclerosis, you may very well be able to see ultrastructural changes by MRI that would not be evident at lower field strengths or in an in vivo sample.
Dr. Klein, just looking at that on a coronal view, how is that the head or the tail? And how can you tell?
So those digitations that I mentioned, so this is a cross-section through the head of the hippocampus, this upper image here. So usually you can see these sort of digitations here, which tells you that you're close to the front. And also there's a transition from the head of the hippocampus into the amygdala, which has a little bit of a more amorphous sort of quality to it in terms of how it looks on a scan. It's more of just a blob instead of the nice structure that we see here. So if we went any more anterior here, we would probably start to get into the amygdala. And then as we go more posterior, so you can see these two sections are represented here, we see kind of a flattening of the top of the hippocampus. This is obviously the temporal horn of the lateral ventricle sitting above the hippocampus, and the nice transition of white matter coming out of the hippocampus, as we mentioned before, and up here as well. Great, so moving on. So this is what it looks like to get to your question in a real example. So this is a normal hippocampal head. And again, towards the front of the hippocampus, you can very often see these very nice digitations here, the kind of finger-like projections coming off of the superior surface of the hippocampus, as we see here. And as we get back into the body of the hippocampus, tends to be a little bit more rounded, maybe slightly smaller than at the head of the hippocampus here. So these are nice normal examples of what a hippocampus should look like. And these are coronal T2, not FLAIR, but T2 weighted images. And you can tell that because not only is the CSF bright, but white matter is dark on a T2 weighted image, as we see here, and cortical structures where the neuron cell bodies are appear bright on a T2. So the big question of hippocampal sclerosis, and this is maybe the most interesting point about this condition, is trying to understand whether the seizures produce the hippocampal sclerosis, or is it the hippocampal sclerosis that sets you up for seizures? And the answer is probably yes to both of those. So, and I tried to kind of represent that phenomenon here, which is to say that if you have hippocampal sclerosis, it increases your risk of seizures. Seizures can result in changes in gene expression, which themselves can result in hyperexcitability and a loss of electrophysiologic homeostasis, which of course can then produce seizures. With ongoing seizures, obviously, if they're not controlled with medications over time due to accumulations of calcium intracellularly and loss of homeostasis, you can end up damaging the neurons in an irreversible way. And once you've done that, that can lead to what we think of as hippocampal sclerosis and so forth. So this ends up becoming a little bit of a continuous loop of damage and of clinical seizures, or at least seizures that you can detect by EEG. Now, when we really get into the sort of histology and cellular damage that's occurring in the hippocampus, just to mention some of the things that you might see histologically, as we looked on the first image, what we saw was gliosis and neuronal loss. So that's kind of the hallmark pathologic findings of hippocampal sclerosis. But what you really end up seeing is segmental loss of hippocampal pyramidal neurons, selective loss of inhibitory interneurons, You can see abnormal sprouting of axons. Some of that may be responsible for the signal change that we see in association with the sclerosis as well. There's reorganization of neurotransmitter receptors, alterations in second messenger systems, hyperexcitability of the granular kind of supporting cells, and extrahippocampal pathology is common. And that last point, I think, is particularly important because when we come across a patient who has hippocampal sclerosis and we're doing a survey of the imaging of their brain, we have to look very carefully elsewhere because you're very likely to come across other lesions that can predispose towards seizures. And those can include things like malformations of cortical development that can coexist with hippocampal sclerosis as well.
This issue of dual pathology, or two lesions, one in the hippocampus and one somewhere else, how do you think of that? Do you think of it as one lesion outside the hippocampus kind of causes seizures and eventually injures the hippocampus, or the other way around, or do you see both?
I think we don't know. I think it's a Venn diagram where there's an overlap of people with dual pathology, and then there's obviously those who have a single malformation of cortical development that's outside of the hippocampus, and obviously patients like the one we're talking about here who just has a lesion in the hippocampus. But there certainly is an overlap, and so it really raises not only the stakes as a radiologist to not miss those extra hippocampal lesions, but I think reinforces the importance of the clinical correlation. Because in this case, we didn't really hear about what this patient's seizures were like, but presumably they had characteristics that clued us into a medial temporal semiology. But when we're contemplating things like temporal lobe resections, we want to be sure that there's not seizures emanating from other parts of the brain that could be producing other symptoms. Because the last thing you want to do is do a resection and then find out that you haven't treated the epilepsy because there's either another lesion or some other semiology of seizures.
Right. We often see patients who have seizures that come from both hippocampi or seem to. How often, or how do you think of that? Coming about?
So that's really one of the tricky things in imaging, and I think also in the field of clinical epilepsy, because certainly there are patients who have bilateral hippocampal sclerosis. I think when they have the amount of sclerosis, as we saw in this image, it's easy to see that it's bilateral when it exists. But the tricky thing can be sometimes one side, sometimes it's a little asymmetrical, and sometimes it's hard to tell if the normal side is truly normal. Yeah. So, if there is that asymmetry, it's really going to come back to the EEG data, other imaging modalities that could potentially help to localize things, and then the clinical semiology to understand whether there are multiple semiologies of the seizures that might point to one hippocampus or the other or elsewhere, as we just talked about. But certainly the problem of bilateral hippocampal sclerosis is a real one.
Sometimes, surgeon will look at the images and say, that hippocampus can't be doing anything. It's, do you think it's possible, or how well do you think it's possible to predict the level of kind of, impairment the patient has, or put another way, the risk that there would be if you take it out from just looking at the imaging?
Yeah, I would exercise a lot of caution in that regard. And what your question made me think of is, the patient who's cognitively normal, and you do a scan of their brain, and they have a pea brain, they have a ton of atrophy. And on the other hand, patients who are quite demented and occasionally have brains that really don't show a whole lot of structural change, of atrophy. So I suppose the same thing could happen in the hippocampus, where you might encounter a hippocampus that looks abnormal due to sclerosis and due to volume loss. But I would be very careful in assuming that there's a direct correlation between that atrophy and the functionality of the hippocampus.
And just to make it really clear, Dr. Klein, so the gliosis there is represented by increased signal and neuronal loss by atrophy and or abnormal architecture. Is that correct?
Yeah, that's right. And so, the gliosis is most evident on a T2 image. So you'll see the hyperintensity there, but the neuronal loss will also result in abnormal darkness on the T1 weighted image. So you can see both of those findings. And generally T1 weighted images, because gray matter is gray and white matter is white, it's very easy to see whether, or it's a nice sequence to look at the structure of the brain, and a nice one to be used to look at, at volume loss. And you can actually do volumetric studies in a kind of semi-automated way to make calculations about how much atrophy there is. And this is done not only in epilepsy, but in in cognitive behavioral neurology as well. Can't resist talking about the hippocampus without getting into a little neuroanatomy, but just before I get there, just to show you these nice histological examples of what hippocampal sclerosis can look like. And again, just emphasizing how particular the sclerosis can be. So sometimes, as you see here, there can just be a focal dropout of neurons in the CA1 area of the hippocampus. Here, it's a little bit of a broader area of CA1 and CA4 as well. In this one, it's just at the sort of end structure here. And in some cases, you can have total hippocampal sclerosis. So it's a really interesting and heterogeneous problem that, that there's certainly different subtypes of. I think the genetic underpinnings or the molecular underpinnings of why particular areas become involved, as we see in these examples, is not completely understood yet, but completely fascinating in terms of what might produce epilepsy and what could become clinically significant. When we mention the hippocampus, I think as neurologists, we should always think about where the hippocampus projects to and what kind of structures project into the hippocampus. And so as we are probably all familiar, this gentleman named James Papes wrote a paper in 1937 called The Proposed Mechanism of Emotion. And here he identified a variety of structures that were linked to each other and that had to do with kind of working memory and its relationship to emotion as well. So here we're talking about the hippocampus, the mammillary bodies of the hypothalamus, the anterior nucleus of the thalamus, the cingulate body and the cingulate projections here of the cortex, which ultimately projects back into the hippocampus. So there's a sort of loop there of structures that is thought to help us with our working memory. So if you ask me to remember somebody's phone number or a medical record number, the process that keeps that active in my brain is presumably going through such a network like this. So the interesting part of this, when we talk about hippocampal sclerosis, is that when you have atrophy of the hippocampus, you can actually see atrophy of its projections and atrophy of the mammillary bodies of the hypothalamus. So this is an example of a patient with left medial temporal or hippocampal sclerosis here, 2 images from the same patient. And not only is there atrophy and sclerosis of the hippocampus, but if you look at this structure here, which is the fornix, this is actually the white matter pathway, the axons that are leaving the hippocampus on their way to the mammillary bodies here in the hypothalamus. This is what a normal mammillary body should look like. And in this case, not only is the fornix atrophied, but the mammillary body is almost absent. So you can see that atrophy that extends beyond the hippocampus. So in my practice, when I'm looking at these sorts of scans, I don't always focus just on the hippocampus, but I look to see if there's asymmetries in the projections as well. And sometimes you can see, even transsynaptic atrophy, as we see in cases like this. And so we're going to talk about the projections that go from the mammillary bodies up to the next stop, which is the anterior nucleus of the thalamus. And this tract is so prominent that it has a name. Nowadays, we call it the mammillothalamic tract, but it was described by Felix Vic Desir. This is a picture of him. And so this was his fasciculus for a while. Mm-hmm. And again, it's the mammillothalamic tract. You can see the mammillary bodies and the axons heading up towards the anterior nucleus of the thalamus. And it's part of this Papes circuit. And so here's just an example of another patient with hippocampal sclerosis on the left side again. And we can see that there is a little bit of atrophy and scarring of that anterior nucleus of the thalamus. I think what they're trying to show you here is that you can see that there's a little bit of widening of the ventricle here. And the reason for that contour deformity is that you're losing, is that you've lost structure, you've lost volume of the anterior nucleus of the thalamus, which sits along the inferior border of the ventricle, as we see in this image.
Very interesting. I heard that hippocampus came from the seahorse. Is that what it is?
That is the Greek origin of the word.
Cool.
Because of its shape.
Because of its shape, yeah, it's nice.
Well, I think things add up in this case after all, Fabio.
Yeah, I thought I got it really wrong just for a change.
No, fortunately, and this patient, I if I remember correctly, they have some verbal memory problems already on their neuropsychiatric testing.
I think
right.
Yeah,
they did test very well.
Right.
So I think that an ATL will be a good solution for this patient.
Right. It's great. Dr. Klein, any words of wisdom for neurology residents and fellows out there when they're looking at scans?
Yeah, I would say, as clinicians, we should get good at looking at these scans ourselves, and don't rely on the radiologist's read. The clinical history. You've had a look at the EEG. You know where to look specifically. If a scan is read as normal and you see something that doesn't look right, have a discussion with the neuroradiologist. If you can find a neuroradiologist that is particularly comfortable with familiar with the lesions that are associated with epilepsy, all the better. It's a question of pretest probability. So if you go into the scan with a hypothesis about where the lesion is, you're much more likely to pick it up. And there's been a variety of studies that have shown that. So that would be my advice.
Awesome.
Excellent. And thanks for bringing up Reverend Bays.
Couldn't help it.
He's always welcome on the show.
Indeed.